everyone. Thank you very much to all the attendees for this great biliary atresia symposium. So now, after a very complete and high-level surgical and clinical talks, Dr. Carpen, Davenport, and Becerra, and then a very impressive translational work of Becerra and Dr. Wells, we jump now to more outstanding translational research talks, which comprise the final two talks, after which there will be the meet the expert session and closing remarks. The next two speakers are outstanding, and we are really fortunate there to hear their talks in a moment on both the single cell level high resolution data by Dr. Jusia Swan and the high throughput genetic studies by Dr. Paul Tam. Of note, I just want to really appreciate the fact that Dr. Jusia Thang and Dr. Paul Tam are 11 hours ahead of us. So for them it's now 2:30 a.m. And we really appreciate this effort that you are doing for the biliary atresia community. So I switch to Dr. Juan Bayo, who will introduce Dr. Sang.
Thanks, Joseph. So I'm so glad to present Dr. Xuxia Zhang. Dr. Zhang obtained her PhD from the Chinese Academy of Science in 2007, followed by a postdoc at Dr. Root Laboratory in Cambridge and a 7-year position at Dr. Harrison Laboratory at Walter and Eliza Hall Institute of Medical Research in Melbourne, Australia. Since 2016, she started her own lab at Wunso Women and Children's Medical Center. She is supported by the Guangdong Province University, the College Pearl River Scholar Funded Scheme, and the National Science Fund for Distinguished Young Scholars. And on her lab, they focus on chronic childhood illness, including pediatric inflammatory bowel disease and biliary atresia. And in the last year, she had performed really high-level science. She has 2 beautiful papers in Cell, and currently they are investigating the pathogenic mechanism underlying the post-Kasai cholangitis. And today she will share with us a great history where they studied and target the immune system in biliary atresia. So all yours, Ruxia.
Well, thank you, Dr. Zhong. I'm going to share my screen. So it's really a great pleasure to speak at this symposium. Well, I hope I can speak clearly because it's 4:30 a.m., but I'll try my best. So today my topic is single cell analysis of biliary atresia. So I actually started this disease because one of my friends, her daughter actually was diagnosed with biliary atresia at about 2 months. And after the cassette procedure, the bilirubin level was still high. So the child had a liver transplanted about 6 months of age. And after that, the child had to continue with this continue with this drug to keep the liver. I mean sorry, I can't remember the terms. My brain is stopped working for the moment. So this whole process actually inspires me and drives me to understand about this very dramatic pediatric disease. So why the pathogenic jaundice couldn't be cleared in the neonates, and what happens in the liver and the intestine at the time of diagnosis, and whether we can prolong the native liver survival of these patients. So the biliary atresia, like the introduction earlier, the topic earlier, the incidence is actually much higher in East Asian populations, and it's around 1 in 5,000 to 8,000 live birth, the incidence. And without a cassette procedure, most of the children just require liver transplantation or die very rapidly. But even after cassette operation, then still over 50% of the children need liver transplantation eventually. So we wanted to understand at the time of liver transplantation what kind of immune deviation in the liver can actually promote liver failure after this cassette operation. So we did this single cell analysis of the liver biopsies from children with biliary atresia and with the control children with cholestasis but normal liver function. So one of the unexpected finding was that we actually identified hepatic stem cells and the progenitors and developing stages of B cells in the infant's liver. And these B cells actually share similar transcriptome developing stages and transcriptomes compared to blood-derived B cell progenitors. So why this is actually, and this B cell lymphogenesis actually lasted for quite some time in the infant. When we look at the children who had the surgery at different time points, we noticed this B cell genesis actually lasted at least about 4 months of life in the early infancy. And at the time of biliary atresia, what we observed was, there were high levels of B cell activating factor BAF, which was produced by myeloid cells in the liver. And this cytokine is actually really important to increase autoantibody production by the progenitor and immature B cells. So when we look at the BAF concentrations in the liver and the autoantibody, such as ROSSE, IgG specific autoantibodies, they are actually positively correlated, and the concentration is really high in infants with biliary atresia. I just missed this page because we know for B cell development, the precursor B cells, majority of the BCRs in the precursor and pre-B cells is actually self-reactive. And in the bone marrow, the self-reactive BCRs need to be edited from the periphery, from reaching the periphery. And this process is called central tolerance. But when this B cell genesis happens in the liver, and supposedly this mechanism is potentially compromised. So in the face of neonatal infection or injury, the availability of self-antigens and a strongly self-reactive BCR would activate the strongly self-reactive BCRs and then generate this autoreactivity. And that's what we saw from the single cell RNA sequencing data and the antibody profiling from the liver of biliary atresia infants. So we actually also noticed when we look at the antibody isotopes in biliary atresia, and if they have higher IgM concentration and lower IgG concentration, their prognosis, native liver survival is much better than the opposite trend. And the reason behind that is the IgM antibodies is quite often self-protective, like antimicrobial and removing damaging cells from the circulation, while IgG4 antibody is quite pro-fibrogenetic. So this ratio is actually reflecting fibrosis processes after cassette procedure. So we know B cells actually not only producing autoantibodies in this setting, it's also antigen presenting cells, which means they could activate T cells and other cells like they can interact with dendritic cells or macrophages in their surrounding environment by the MHC TCR interactions or antibody FC receptor interactions. So the activated B cells not only producing self-antibody, but activate T cells like cytotoxic T cells or Th1 type cells. And these cells are well known for causing biliary atresia type of pathology, causing autoimmune liver destruction. And with biliary extrahepatic biliary duct obstruction, which Dr. Wells just talked about very nicely. The consequence would be the bile acid and other contents would accumulate in the liver. And this process is actually also altering the immune profiles in the liver. So what we noticed is the macrophages in the liver actually have a reduced inflammatory potential to produce inflammatory cytokines. And this was actually caused by the activation of a CAMP, the second messenger receptor pathway, which is in general anti-inflammatory. So apart from macrophages, we also look at Kupffer cells from biliary atresia and control subjects. And when we took out the Kupffer cells and performed the scavenger function using FITC labeled bacteria, what we observed was the Kupffer cells from infants with biliary atresia was incapable of removing this bacteria, scavenging this bacteria. So not only the defects about T cells, B cells, and macrophages, the bile acid also produce additional effects on some new types of CX3, CR1, a chemical receptor expressing CD8 and NK cells. So what we observed was a significant reduction of these proliferating T cells. And what these T cells were doing in the context of liver fibrosis was so these T cells inject their cytotoxic granules into the hepatic stellar cells and kill the hepatic stellar cells as a way of controlling fibrosis. But in the presence of bile acid, the receptors for these T cells, like the CX3CR1, and also the ligands secreted by these hepatic stellar cells are both reduced in biliary atresia. So based on these studies, we thought the B cells are playing quite a central role in the pathogenesis of biliary atresia, which is actually not new in this field. But we want to study what happens if we deplete B cells to biliary atresia. So we also use this rotavirus-induced BA model, and we separated B cells according to their differentiation stages, like the B1A cells or the immature and mature B cells. What we found is if we deplete B cells like this blue line, and then the biliary atresia incidence was significantly reduced compared to the RRV-infected neonatal mice. And what is more importantly is if we blocking antigen presentation, particularly from MHC class 1 or class 2 mediated antigen presentation, and then the protective effects for biliary atresia development were more dramatic. And B cell depleting strategy here we can see is actually no 100% protection. And the reason behind this is what we found, the ones still developed jaundice is actually having much higher B1A cells, which is kind of innate like B cells producing autoantibodies. And also the pre-pro B cell population in this RRV infected mice are also much higher in the non-responder group compared to the antibody responding group. And also after B cell depleting therapy, we look at the Kupffer cells and noticed their scavenger function was restored after anti-CD20 mediated therapy or anti-MHC class 1, class 2 mediated therapy. And at the same time, the CX3, CR1 and CX3, CR1 anti-fibrosis process was also restored. For example, the ligand concentration was increased. And in addition, we observed increased concentrations of C1q complement system component, which is actually known to suppress cytotoxic T cell mediated cytotoxicity. So based on these studies, we did Rituximab clinical trial because this drug at that time was available in our hospital. So we studied 4 subjects and then just gave them half dose of conventional Rituximab antibody. So after this injection, we noticed the autoantibody concentrations in the serum were significantly decreased in these patients, and they lasted for quite some time. But the ones without the therapy can have a continuous rise in the concentration of autoantibodies. And this therapy, as expected, removed not the stem pro B cells, but just the immature and the transitional and naive B cells, and left to the plasma blast and plasma cells in the liver. And so these 4 patients actually eventually still occurred cholangitis, and some of them underwent liver transplantation. We haven't gone into a random controlled big scale clinical trial, so we still don't know whether this therapy would be beneficial in the setting of biliary atresia. It would be affected by many factors such as time of operation and the adjuvant therapies after Cassez operation. Because some of the patients still occurred cholangitis, so we were wondering whether this therapy would cause unwanted responses, for example, in tissues rather than liver. So when they have this Cassez operation, they actually take a piece of small intestine and then link it to the extrahepatic duct remnants. You're more familiar with this than I do. So we took these small intestine biopsies from the patients after this Cassez procedure, including 2 patients after Rituximab therapy. What we actually observed was because the IgA producing B cells in the gut are quite important for gut protection from microbes and for maintaining gut health. So what we observed was the B cells, the liver-derived B cells are actually actively seeding into the small intestine. And after B cell depletion therapy, the IgE producing B cells seem to be increased in numbers and exhibit some features of redox repairment. So it actually doesn't look like this therapy would cause dramatic impact on the protective IgA responses in the intestine. So it probably still was trying in a more controlled clinical setting about B cell modifying therapies. So so I just want to very briefly to summarize what I just described. So at this time of Cassette's operation, and we hypothesized majority of the biliary atresia was caused somehow by viral infection of the neonates. And under this viral infection, the macrophages probably in the liver actually having activated type 1 interferon pathway, and this activation elevates the expression of BAFF, while at this time the B cell lymphogenesis occurs in the liver. The autoreactive B cells would be selected and activated by cytokines such as BAFF, and then start to producing autoantibodies. The autoantibody producing B cells also act as antigen presenting cells to activate the T cell immunity, which contributes to cell death and liver damage at this process. And while the bile acids accumulated in the liver is actually reinforce this damaging process, and at the same time suppressing the repair pathway. So it's the time of Cassette's operation. If we stop this excessive B cell mediated autoreactivity, we could potentially prolong the native liver survival for these patients. And based on this hypothesis, we actually did more studies. We actually have data supporting that if we block type 1 interferon signaling pathways using an anti-IFNA antibody or JAK TYK2 inhibitors or anti-BAFF antibody, and they can equally achieve sometimes even better therapeutic effects in RRV-induced BA model. And we also trialed at the clinic using anti-BAFF mediated therapy and compared that to Rituximab mediated therapy. And this therapy is non-depleting compared to Rituximab, and the clinical limited evidence from the clinical aspect seems to be promising at this time. So today I am just from the single cell RNA sequencing study, we just come up with this potential treatment for prolonging self-liver survival by targeting B cells or cytokines that mediate B cell activation. And for this clinical trial to be successful, it could be really important to do this clinical, to do this intervention at earlier time points. And it is potentially also important to consider accompanying therapies, particularly such as nutrition and nutritional support. And also from, there are other considerations, for example, the dysbiosis or cholangitis after Cassette's operation and the high prevalence of allergy in these patients are actually related, very closely related to the small intestine or intestinal health of these patients. And from the single-cell RNA sequencing studies, we actually obtained evidence that if we are providing additional nutrition, and the incidence of cholangitis will be reduced significantly after this combinational therapy. And with that, I would like to acknowledge my collaborators. So I'm working in a pediatric hospital. So yeah, Dr. Huimin Xia and Wenjie, and they are the pediatricians and surgeons I work closely with, and for single-cell RNA sequencing studies and all the functional studies. And there are lots of contributions from my collaborator from Peking University, Bai Fan, and also Yan Huixu, Wang Jun, and Zhang Hua from the lab. And I would like to acknowledge the funding from my hospital and the national funding, Guangdong province, provincial funding for these studies. Thank you.
Thank you so much, Sunxia. Beautiful talk. So, Dr. Restore asked, did you check the cytomegalovirus in the babies analyzed by single cell? So, if you know the status of those patients.
Yes, so we didn't, for that particular study, we didn't look at CMV infection. But in our hospital, the previous study suggested about 80% of liver can be CMV RNAs can be detected, genome can be detected in the liver of these biliary atresia patients. We actually did extra studies on the small intestine and liver. We detected other virus integration into the genome in these patients. We're still looking to find how this integration of CMV and other virus does to biliary atresia.
Lucia, thanks for this great talk. I enjoyed a lot with your paper and with your conference today. I congratulate you for this work. Is huge and is great precision and high resolution. So I wanted to ask you, are you thinking on sequencing the BCRs to understand what could be the antigens that have been detected by these abnormally activated B cells, or could the clonality or the diversity detected in plasma or in the blood of the kids reflect what's going on in the liver?
Yes, so we actually did BCR sequencing in this published study. So the results pretty much there's defects in BCR editing and likelihood of more autoantigen specific BCRs, but we didn't do autoantigen screening to say what all the other types of autoantibody positivity. But we did quite a few, like 3 or 4 of autoantigens have similar result.
Really good.
So Dr. Carpen asked if you are planning to do a controlled clinical trial planned for other of your therapeutic ideas that you presented, the anti-BAF or maybe something like that?
Yes, so at the moment we we have been trying to test is a few of these therapies, like Rituximab and anti-BAF. I think the limited evidence actually prefer anti-BAF treatment over to Rituximab treatment because it's less dramatic. It's inhibiting B cell activation. And on top of that, from our experience now, is the nutritional support is really important. So earlier today, there was a talk about different prevalences of biliary atresia in Asia and the different other countries. I think the maternal, during the pregnancy, the nutrition guidelines and the micronutrients is actually quite different between these different places. So at the moment, acceptable, and besides vitamin A, D, E, K, which Dr. Badera talked about in this biliary atresia management, the small intestine is actually also showing evidence of requiring additional antioxidants or vitamins to support or to suppress co-entities development. So at the moment, we are actually testing the combination of additional vitamins and anti-BAF antibody as a combination therapy to reduce biliary atresia incidence, to improve the prognosis.
There is a question from Dr. Davenport. Dr. Zhang, do you really have clinical data in post-Kasai infants with biliary atresia using these anti-inflammatory antibodies? I guess he's referring to other than these 4 babies. Do you have any other data from other cohorts treated with rituximab?
Yeah, so I think altogether we probably had about 7 patients. We did additional 3 patients after the paper, and the small intestine profiling was also performed on these 3 patients. Only 2 data sets were available, probably one field of for technical reasons. And we also generated anti-BAF treatment. So these are often, the children normally stays in the hospital for about 1 or 2 weeks. And after the diagnosis, they have been given these trial antibodies for 5 to 7 days. And when they perform the cassette procedure, then we get the biopsies to test what happens after this immunomodulatory therapies. Yes.
Okay. So I guess there's new randomized control trial to plan ahead of us with this really very inspiring preliminary data. With this, I think we have to switch to the next